Welcome to A&P Live Studio. I'm your host. As a registered nurse and an anatomy and physiology instructor for advanced healthcare professionals, my whole goal here is to connect the dots between the complex science of physiology and how it plays out in the real world, right at the patient's bedside. Today, we're going to tackle two incredibly important topics: advanced cardiac life support, or ACLS, and the four major types of circulatory shock. So instead of cracking open a textbook, let's begin where it all matters most, with a patient. This is a situation that any of us in healthcare could walk into at any moment, whether you're in the ER or the ICU. Okay, right away, these numbers are screaming trouble. Our patient's blood pressure is 75/40. That's profoundly hypotensive, dangerously low. His heart's racing at 135 beats per minute, which is a classic compensatory tachycardia. His heart is trying, it's beating as fast as it can to make up for that low pressure. His oxygen saturation is down to 88%, which tells us he's hypoxic. Not enough oxygen is getting to his tissues. And his mental status? Obtunded. He's barely responsive. These are all huge red flags that something is failing on a massive scale. So let's put a face to these numbers. This is Mr. David Johnson. He's a 68-year-old African-American man, and his history of high blood pressure and coronary artery disease puts him at significant risk for exactly this kind of event. He comes in looking pale, he's sweaty or diaphoretic, and you can just tell he's in serious trouble. And then it happens. He suddenly becomes unresponsive. To understand what's going on, and more importantly, how we can possibly fix it, we have to dig into the pathophysiology. To really get what's happening to Mr. Johnson, we have to look past the vital signs on the monitor. We need to zoom in, way in, all the way down to the cellular level, because this is where every single crisis in the human body truly begins. What we're seeing here is a state of shock. And shock is so much more than just low blood pressure. It is a fundamental failure of the entire circulatory system. At its core, it means oxygen isn't making it to the cells. And without oxygen, those cells can't produce energy to do their jobs. This creates a massive oxygen debt that kicks off a pretty devastating chain reaction. So what's actually going on inside Mr. Johnson's cells right this second? Well, it all starts with hypoxia, no oxygen. The cell panics and switches from its normal, super-efficient aerobic metabolism to a last-ditch anaerobic metabolism. And here's the kicker. This backup system is about 18 times less efficient. So ATP, the energy currency of the cell, just plummets. Without ATP, critical things like the sodium-potassium pumps just stop working. The cell starts to swell up, calcium floods in, and toxic lactic acid builds up. If we don't fix this fast, this cascade ends in one place: cell death. This whole cellular meltdown, well, it doesn't just happen out of nowhere. You can think of it like this. There are 4 different highways that can lead to this same terrible destination of circulatory collapse. And understanding which road the patient is on is absolutely key to knowing how to intervene. This table is awesome because it really simplifies things with a great analogy. Imagine your circulatory system is a city's water system. In hypovolemic shock, the tank is just empty, not enough fluid. In cardiogenic shock, the main pump is broken. The heart itself can't work. For obstructive shock, there's a blockage in a major pipe. And then there's distributive shock, where all the pipes have suddenly gotten leaky and wide, causing the pressure to just disappear. You'll notice the first 3 all have low cardiac output. They're low flow problems. But distributive shock is different. It's a problem of low resistance. All right, first up, hypovolemic shock, our empty tank problem. This is pretty straightforward. You've lost volume from inside your blood vessels. It could be from obvious bleeding, which we call hemorrhagic shock, or from losing other fluids, like with severe dehydration or massive burns. The end result is the same: less blood is returning to the heart. We call that returning volume preload, and it's simple, right? If less blood comes into the heart, less blood can be pumped out. Your cardiac output tanks. Next, we've got cardiogenic shock, the broken pump. Here, the problem is with the heart itself. The number one cause is a big heart attack, a myocardial infarction that damages so much heart muscle that it just can't squeeze effectively anymore. The pump's contractility is shot. This not only means less blood gets pumped forward to the body, but it also causes blood to back up, leading to things like fluid in the lungs. Then we have the blocked pipe, or obstructive shock. Now, this one's a little different because the heart muscle itself might be perfectly healthy, but something outside the heart is physically blocking the flow of blood. Think of a huge blood clot in the lungs, a pulmonary embolism, blocking blood from leaving the heart. or cardiac tamponade, where fluid builds up around the heart and squeezes it so it can't fill. And finally, distributive shock, are leaky pipes. This is all about massive body-wide vasodilation, where your blood vessels get all floppy and lose their tone. The classic example is septic shock from a bad infection. In this case, the amount of blood in your body might be totally normal, but the container, your vascular system, has suddenly become enormous. It's what we call relative hypovolemia. It's like having 5 gallons of water in a swimming pool. The volume is there, but the pressure is gone. Okay, so let's get back to Mr. Johnson. He's now unresponsive. He has no pulse. This is where all that pathophysiology we just covered has to be put into action immediately. This is what advanced cardiac life support is all about. It's applied pathophysiology under extreme pressure. The second we get the monitor pads on Mr. Johnson, there is one question, one single critical question that we have to answer, and it determines everything we do next. Is the rhythm shockable? This one decision splits the entire cardiac arrest algorithm into 2 very different paths. So this is absolutely crucial. On one side, we have our shockable rhythms, VFib and pulseless VTAC. In these, the heart's electrical system is chaotic, but it's still trying to do something. Our job is to defibrillate, to deliver a massive electrical shock and hopefully hit a reset button. On the other side, we have the non-shockable rhythms, asystole, which is just a flat line, and PEA, where you see electricity on the monitor, but the heart isn't actually pumping. For these, a shock is useless. Our only goals are amazing CPR and finding out why this is happening. So if Mr. Johnson is in VFib, what do? Boom, we shock him immediately. The whole point of that shock is to stun the heart and give its natural pacemaker a chance to take over again. Right after the shock, we're back on the chest doing high-quality compressions to keep blood moving. Then we give epinephrine. Its main job is to squeeze the blood vessels, which raises blood pressure and helps get blood flow to the heart muscle itself. If the VFib just won't quit, we can try an antiarrhythmic drug like amiodarone to help calm things down. But what if he's an asystole or PEA? The game plan is totally different. Here, high-quality CPR is king. It's the only thing creating any blood flow to his brain. We give epinephrine as soon as we can to help with that, but the most important thing we do is think. We have to be asking, why did he arrest? We have to hunt for a reversible cause, because a defibrillator isn't going to fix the underlying problem. And that hunt for a reversible cause brings us full circle, back to the system-wide consequences of shock. The cardiac arrest isn't the beginning of the story. It's the final dramatic chapter of a failure that's been impacting his entire body. And this is our cheat sheet for that hunt, the H's and T's. This is a list of the most common and, most importantly, reversible causes of cardiac arrest. And look closely, you can see our types of shock hiding right in this list. Hypovolemia, that's hypovolemic shock. Tension pneumothorax and tamponade, those cause obstructive shock. A big pulmonary or coronary thrombosis, that's obstructive or cardiogenic shock. If we can find and fix one of these, we might just be able to get him back. This chart is a sobering reminder of what happens when shock goes on for too long. The lack of blood flow leads to multi-organ dysfunction. The kidneys shut down, the lungs get severely injured, the brain suffers from lack of oxygen. It's a domino effect. It really drives home how interconnected our organ systems are. And if you use that MRS includer mnemonic, you can see how failure of the cardiovascular system just cascades through the respiratory, nervous, urinary, and digestive systems. They all go down together. So let's pull all of these threads together now. We've journeyed from Mr. Johnson's bedside down into his cells, we've explored the 4 main types of shock, and we've walked through the ACLS response. There is a clean, logical line that connects every single one of these steps. This is the story, right here. You start with normal physiology. Then, a pathophysiological insult, one of those 4 types of shock, throws everything off balance. That leads to the clinical presentation we see at the bedside, which can end in cardiac arrest. And our response, the ACLS algorithm, is a set of logical interventions specifically designed to counteract that pathophysiology. It's not just a list of rules to memorize, it's a roadmap for thinking through the crisis. Understanding the why behind every action we take is what separates good clinicians from great ones. I really hope this session helped you see those critical connections. As always, stay patho-curious. This A&P Live Studio is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions.